Welcome to this medicine masterclass in which we'll be having a case-based discussion around mitral regurgitation. Mitral regurgitation results from the incomplete closure of the mitral valve, causing abnormal blood flow from the left ventricle through the incompetent mitral valve back into the left atrium. Patients can often be asymptomatic or may develop exertional dyspnea and fatigue and can develop paroxysmal or persistent arrhythmias such as atrial fibrillation. So let's take a case. Mr. Jones presents with exertional shortness of breath. Let's discuss the cardiovascular examination findings and have a case-based discussion. So present the findings using an inspection, palpation, auscultation approach. On inspection of a patient with lone mitral regurgitation, the apex would appear normal with no scars. On palpation, with a regurgitant murmur, the regurgitation would increase the stretch of the ventricle, resulting in a displacement of the apex beat into the 6th intercostal space left anterior axillary line and results in a thrusting apex beat. On palpation, no heaves or thrills would be palpable until more advanced disease. On auscultation, heart sounds 1 and 2 would be present and S1 would be soft. The mitral valve and the tricuspid valve contribute to S1. S1 is diminished, reflecting inadequate opposition of the mitral leaflets due to mitral regurgitation. The murmur itself is described as a pansystolic murmur, auscultated loudest over the mitral area. To accentuate this, the patient leans laterally and expires, and the murmur radiates into the left axilla. Remember that the murmur is best heard over the apex, and the mitral regurgitant jet is directed posterolaterally due to the anatomical location of the heart, and that's why the radiation is to the axilla. When the murmur is very loud, it may also radiate to the posterior left thorax too. So putting this together, Mr. or Mrs. Jones presents with shortness of breath. The patient was comfortable at rest, and I believe the patient has signs consistent with mitral regurgitation. On inspection, the precordium appears normal with no scars noted. The apex beat was displaced, found in the 6th intercostal space, left anterior axillary line, and thrusting in nature. On palpation, there were no heaves or thrills palpated. On auscultation, heart sounds 1 and 2 were present, S1 was soft, and a grade 3 pansystolic murmur was auscultated, loudest in the mitral area and accentuated with the patient leaning laterally towards the left in expiration, and the murmur radiated to the left axilla. The pulse was regular, maybe jerky in nature, and there was no radioradial or radiofemoral delay, and the JVP was not elevated and had a normal pulsatile waveform. So what are the differentials for mitral regurgitation? Given that mitral regurgitation is a systolic murmur, other systolic murmurs include tricuspid regurgitation, aortic and pulmonary stenosis or aortic sclerosis, mixed mitral valve disease, as well as mitral valve prolapse. Now let's take a moment to distinguish mitral regurgitation and mitral valve prolapse. Mitral valve prolapse is valvular heart disease characterized by the displacement of an abnormally thickened mitral valve leafment which prolapses into the left atrium during systole and is considered a benign condition. The murmur of mitral regurgitation can be distinguished from the murmur of mitral valve prolapse. In mitral valve prolapse, you will hear a mid-systolic click, and that occurs when the mitral valve apparatus tenses as the leaflets prolapse into the left atrium in systole. Moreover, the murmur of mitral valve prolapse is a late systolic murmur, whereas in mitral regurgitation, the murmur is pansystolic. In terms of accentuation, the murmur of mitral regurgitation will increase when you increase the blood flow into the heart. So if you were to raise the patient's legs or ask them to squat to increase the blood flow through the valve, the murmur of MR would increase. Whereas increasing blood flow into the heart normalizes the prolapsed mitral valve and abates the murmur of mitral valve prolapse. And similarly, the murmur of mitral valve prolapse increases with standing or Valsalva maneuver, whereas the mitral regurgitation murmur would decrease. So quite a few ways to distinguish these two conditions clinically. What are the causes of mitral regurgitation? Acutely, the rupture of the chordae tendineae muscles as a result of myocardial infarction or advanced infective endocarditis or rheumatic fever would result in mitral regurgitation. Traumatic damage to the valve would also result in mitral regurgitation, but chronically, rheumatic fever or gradual left ventricular dilatation would result in MR. Connective tissue diseases such as Marfan's syndrome, Ehlers-Danlos syndrome, rheumatoid arthritis, SLE, cardiomyopathies would result in mitral regurgitation. So to investigate these patients, again using the B-fish mnemonic, where we're investigating their bloods, any fluids that we can assess, imaging, special tests, and then reviewing these tests in light of previous tests to see whether the condition is progressing or regressing. So the bloods that we'd look at would include an FBC, U's and E's. CRP and ESR would be helpful to determine whether there's an acute infection or whether there's any rheumatological conditions or vasculitides. Blood cultures are relevant for infective endocarditis. A troponin would be very important if there's an acute mitral regurgitation in the presence of chest pain or acute coronary syndrome. ANA and autoantibody screens can be helpful in rheumatological and autoimmune conditions such as SLE, and we can also organize a syphilis screen. ECG is useful to determine whether there's any underlying ischemia or acute coronary syndrome, and whether there's a presence of arrhythmias or consequential atrial hypertrophy, which manifests as bifid P waves, particularly seen in lead 2, and whether there's any left axis deviation. But the key investigation is echocardiography, and this would allow you to assess cardiac contractility, the ejection fraction, whether there's any regional wall motion abnormalities, the chamber sizes, and the valve surface area, and whether there's any other murmurs. And the investigation would allow you to look at the valve surface area, the gradient, and the jet velocity, which will be used in the management of this condition. More advanced and detailed imaging techniques such as cardiac magnetic resonance could be used to detail blood flow patterns, and if you believe that the patient would require surgery, then they would undergo a coronary angiogram to determine whether or not they've got coronary artery disease that would require a coronary artery bypass graft at the time of surgery. Which leads us on to management. Managing such patients requires holistic management, a patient-centered approach, and the involvement of a multidisciplinary team. And there are conservative, medical, interventional, and surgical options. Conservatively, educate the patient about their condition, address any psychological concerns, advocate smoking and alcohol cessation, weight loss if required, optimize their diet, advocate fluid restriction if they're developing heart failure, and if they develop any arrhythmias or syncope, then advise them to contact the DVLA or the driving agency and optimize them for surgical intervention. Medically, if they have any comorbidities, ensure that they're optimized, treat heart failure if heart failure arises, monitor for arrhythmias and endocarditis, and treat appropriately. Surgically, we follow the European Society of Cardiology and the European Association of Cardiothoracic Surgeons joint guidance. In particular, if the patient is symptomatic or the left ventricular ejection fraction is greater than 30%, they should be offered a surgical valve repair to improve their quality of life. If they're asymptomatic or they're developing a poor ejection fraction, then surgery can be considered. However, if they have no symptoms and they have a good ejection fraction with no murmurs and they're a high risk candidate, then they should be followed up closely in clinic. For those patients that do require valve replacement, there are tissue and metallic options. Tissue lasts for about 10 years. Advantages, they don't require anticoagulation and can be used in the elderly. Metallic valves do last longer and so are used in younger patients, but they require lifelong anticoagulation with teratogenic agents such as warfarin, and that can have consequences on young females wanting to become pregnant. So, in summary, we've discussed the mitral regurgitation case presentation, the signs and the symptoms, the differentials, how to investigate and manage these patients. Thank you for attending this medicine masterclass.